Okay, Chris, where do ventricular rhythms originate?
In the atriums. In the
Okay, so by definition, all ventricular rhythms originate in the ventricles below the level of the bundle of His. So the bundle of His is that little strip that comes out of the AV node, and then we're officially in the ventricles. This means that, so Cody, all ventricular rhythms have what? A narrow or a wide QRS? A wide QRS, okay? And, you know, I said this one year and somebody raised their hand and said, but VFib doesn't have a wide QRS. And so now for all the smart Alex students in the audience, I say the exceptions are VFib and asystole, which have no QRS complexes at all. So if they have a QRS complex, it's wide. So who remembers, why do all ventricular rhythms, why do they have a wide QRS? We've talked about this before. Say it again? Cell to cell, okay, good enough. Okay, so just to go through it again, so typical ventricular rhythms originate from one or more ectopic foci in the ventricles, so one of those misplaced pacemakers. And then because of that, the impulse spreads. It goes through the ventricles, but it doesn't have the advantage of the speedy conduction system. It has what we call direct cell-to-cell conduction, and that leads to slow depolarization, which leads to a wide QRS on the ECG. Okay, and just to really hammer this home, if a rhythm has a narrow QRS, if the QRS is less than 3 small boxes, it cannot be a ventricular rhythm, okay? So that 5th step in the 5-step process up to this point, its only purpose has been to say, oh, is there an IVCD or not? Now it's actually going to help us identify ventricular rhythms. So, so for example, Cohen, number 1, is that ventricular or supraventricular? Supraventricular, okay. And what is that, by the way?
Sinus.
What kind of sinus?
I
Normal
wish I had my calipers.
Normal sinus.
Okay. And then, Andrew, what about number 2? Is that ventricular?
Ventricular.
And what is it?
Matt? Paul? Good.
AFib. Yeah, okay. And the reason, part of the reason I'm saying it is, as a rule of thumb, unless it's really obvious P waves, I don't put MAT on my test just because of its difficulty.
The rhythm's
in trying-
irregular, or, yeah, it's
Yeah,
irregular. I don't know why
okay.
I said that, actually.
Yeah, that's okay, you're just warming up anyway. And then Grace, what about the third one? Is that ventricular or supraventricular? 50-50.
I'm looking, I'm trying to see if I don't know.
We don't have calipers.
We're handy.
Well, do your best. And what is it? You're correct. What is SVT? Okay. Oh, and actually, I apologize because you could have used calipers because if you look more on page 25 and 26, I forgot to mention that. You can do it after the fact. Okay, so here are the ventricular rhythms we're going to go through. We're going to talk about PVCs, ventricular escape, accelerated ventricular, VTAC, VFib, and asystole. Okay, so a PVC is it's a premature beat in the same way that a PAC and a PJC is. The only difference is the ectopic focus is in the ventricles. For that reason, because it originates in the ventricles, it's just like any other ventricular, anything else that originates in the ventricles, it's got a wide QRS. And what you're going to find with PVCs and actually ventricular rhythms in general is because the shape of the QRS is really going to be different depending on whether it is the ectopic focus is at the top of the ventricles or the bottom of the ventricles, that all of these QRSs are going to look, have the potential to look different from each other. Okay, so that's why we say even bizarrely shaped. And because it's in the ventricles, there's no P waves. So the criteria for a PVC is the rhythm. Again, it makes no sense to talk about the rhythm of a PVC because there's usually just one at a time. But the underlying rhythm is usually regular. Rate's not applicable. There's no P waves, so there's no PRI. And again, the QRS is always greater than or equal to 0.12 seconds. So, for example, you can see there's an underlying sinus rhythm, and then we have sort of erratically spread out PVCs, a handful of PVCs. And if you look at the PVCs in this example, all of them look the same. And for that reason, because they all look the same, our assumption is it's coming from one ectopic focus, because they all look the same. And the term that's used for that is unifocal PVCs. Now, when I ask you, when I say, what do you see? The answer is normal sinus with PVCs. I don't require you to say with unifocal PVCs. It's not part of the official name, but I do want you to know what's the difference between a unifocal and multifocal PVCs. So the unifocal PVCs all look alike. Our assumption is they come from one place in the ventricles, as opposed to multifocal PVCs, where what's happened is that there's multiple irritable foci in the ventricles that are kind of taking turns firing off, and they all look different depending on where they come from in the ventricles. So again, if I said, what is this? The answer is still normal sinus with PVCs, but I do want you to recognize that there's a difference between unifocal and multifocal. Which one do you think is clinically more serious? And why? That's correct. Why?
Because there's lots of different firings.
Yeah, so lots of different irritable, something has to cause multiple irritable foci. So, let's see, Anne, are these, we have two PVCs here. Are they unifocal or multifocal? They are unifocal, okay. And then, who's got the pointer? This one I want you to, okay, Grace. On this one, point out where the PVCs are. It's not immediately obvious. How many are there? Good, okay. And unifocal or multifocal? Yeah, so let's look at this. In this particular case, each of these PVCs are made up of a QRS and a T wave, and that's all there is. The first one is a negative QRS. The beginning of it's here, it goes down here, the J point is here. So this is the initial QRS, and then there's a T wave. And then it goes right into the second PVC right here, and the QRS, it's flipped. They're each, this one and this one are very similar, it's just that the second one is an upside down version of the first one. So in this case, this one, the QRS is just one big negative deflection. In this one, the QRS, I've cut off the top of it, but is just one positive deflection. The J point's right about here, and it's an inverted T that goes like that. Okay, everybody see that? So this one, my guess is that this one originates near the bottom of the ventricles because the QRS is negative, so moving away from lead 2. So the ventricles are depolarizing from bottom to top. But this one, probably the ectopic focus is up near the top of the ventricles, and the wave of depolarization is moving toward lead 2. And so that's why we have a positive QRS. Okay, so this is what people call bigeminy. And again, you can see the underlying rhythm is a sinus rhythm, so it's sinus PVC, sinus PVC, sinus PVC all the way across. When somebody says, just as I was saying to Kyle earlier in the class, when somebody says, oh, the patient is in bigeminy, this is what they mean. The common, although not very accurate usage, is bigeminy means sinus PVC, sinus PVC, sinus PVC. But just because bigeminy simply means every other, that's all it means. And it could be PACs. You could have PACs in a bigeminal pattern. So again, it's more accurate to say PVCs in a bigeminal pattern, but everybody just says bigeminy. Okay. If you have this on a test, I don't want you to call this bigeminy because I don't think it's accurate. What I want you to say is underlying rhythm, and with PVCs or every other PVCs, or you can say 1, 2, 3, 4, 5 PVCs, or you can say PVCs in a bigeminal pattern. But don't call it bigeminy because I just don't think it's accurate. And then trigeminy, again, is the same thing, except it means every third is when we say trigeminy. And again, when you hear the term, the patient is in trigeminy, they mean PVCs, but that's just not a very accurate way of saying it. And there is such a thing as quadrigeminal, but at that point it gets a little silly. You just say every fourth one is a PVC. Okay, so let's see. So if you look, I'm trying to think what my point was here. Okay, this is strip number 4. Somebody just describe what they see. I really can't remember what the specific question was with this. So, Natalie?
I see PVC in a bigeminal pattern until like 2004.
Right, and what's the underlying rhythm? Don't forget that.
It's like borderline Brady, at least in the beginning.
Oh, that brings up a great question. So what is the underlying rate here? In this case, we can pretty much say what it is, because probably the underlying rate is this, okay? So this looks like about 300, 150, about 75. But the problem is when you just have, if we just look at this half, it's impossible to say what the underlying rate is, because either the underlying rate is about 30 and the PVCs are just happening in between the rates, or the underlying rate is about 70, and if we knock out the PVCs, it's going to come back at 70. So when you have something like bigeminy, it's impossible to say for sure what the underlying rate is.
So what would you put as your answer?
Well, in this particular case, my guess is because once the PVCs stop, they're going along regularly. I would say the underlying rate here is normal sinus rhythm with 4 PVCs in a bigeminal pattern. Okay, so PVCs are generally thought to be clinically more serious than PACs or PJCs. However, the view on that over the years has changed somewhat because it used to be thought that, PVCs are always bad. And then they began looking at the rhythms of healthy young people, and if we were all hooked up to a monitor like a Holter monitor, there's no question there would be some PVCs. We'd see some PVCs, and it's occasional PVCs are thought to be pretty benign. So there's been a bit of a change on that. Okay. Moving along, our next rhythm is called ventricular escape, or idioventricular rhythm, and for reasons I don't know, it's not as commonly just called ventricular rhythm. So pick one, pick either ventricular escape rhythm or idioventricular rhythm. And even though I said idiojunctional is old-fashioned, people still use idioventricular, so I don't know why. Just the way it is. So you'll still hear a lot of people say idioventricular. And so ventricular escape, remember when we talked about what happens if the faster pacemaker dies, you know, if the SA node goes on vacation and the AV node follows suit, the ventricles will take over pacing themselves, and that's what ventricular escape is, okay? You're not likely to see much ventricular escape, okay? It's not a very common rhythm. In a minute we'll talk about why. Ventricular escape is regular, okay, that's important. Rate is less than 40, so it's really slow. There are no P waves, there is no PRI, and the QRS is wide. So this is what ventricular escape is. Now, you're not likely to see a patient in ventricular escape with one exception. It's very rare that you walk in on scene and you put the monitor on and go, oh, look, ventricular escape. I can think of one time that happened, and it was a very unusual circumstance for me anyway, with the exception of complete heart block, but we'll get back to that. When you will see ventricular escape is if you walk in on a code and you get back a perfusing rhythm. That's your most likely time to see ventricular escape. And if you're successful, it's not going to stay in that. And then also, if a person goes to the cath lab, they will see a lot of times the first reperfusion rhythm is ventricular escape. Accelerated escape rhythm, accelerated ventricular escape rhythm is exactly the same, it's just faster. And the numbers aren't the same as junctional, so pay a little bit of attention so you don't make a mistake there. Now, the most common name for accelerated escape rhythm is accelerated idioventricular rhythm, or AIVR. And you're very welcome to use that phrase if you want. You'll hear it like you'll hear it in the ED. People will talk about, oh, the patient is an AIVR. Okay. And again, the most common etiologies for this is reperfusion after the cath lab or ROSC after cardiac arrest. So again, it's regular. The rate is between 40 and 100, and otherwise it's the same. This is what it looks like. No P waves, wide, regular, between 40 and 100. Okay. VTAC. So maybe pulse or pulses. Mostly quite regular. Sometimes there's some slight irregularities. 100, it's over 100. You know, if you're asked what the rate of VTAC is, over 100 is fine. You don't have to put the upper limit on it if you don't want. You may actually see some P waves in a minute. I'll show you what I'm talking about. But they're not, they have nothing to do with the QRS. Okay. So here's VTAC. So sometimes what you'll see, sometimes what's happening, I don't really see it here. I'm trying to see if I see any P waves. What happens with VTAC sometimes is that this rhythm takes over the ventricles, okay? And this, you know, both of these are originating from some ectopic focus in the ventricles, which is probably forming a little reentry circuit, a little micro reentry circuit that's throwing off impulses. But you might say, well, what happens to the SA node during that? And it's possible for the SA node still to be firing off P waves and depolarizing the atria. It's just that it's sort of is blocked from going down to the ventricles because the ventricles are controlled by this, and it's so rapid that the SA node can't take over. But every once in a while, you'll see these little P waves kind of floating through. They have nothing to do with VTAC, but you'll see these little sort of dinks, these little blips kind of floating through the rhythm. Yes.
Are those discernible notches in the VTAC, is that the beginning of the QRS, or?
So in this, these are again flipped versions. So so VTAC is commonly just a QRS and a T-wave, okay? So in the top one, I would say it's the best of my ability here, the QRS begins here, and there's kind of a little SS prime, and then it looks to me like the J point is here, and then that's the T wave, okay?
Okay.
Here it's exactly the opposite, is that the QRS, I don't know, I guess it begins about here, and it goes up, and the J point is somewhere on here, maybe that's it, maybe that little thing there could be the J point, and it's an inverted T.
So like the pointy part is usually
Yes.
associated with the QRS
Yes.
and this rounded is the
Yes.
T?
And sometimes it's easy to tell and other times not, so, yeah. Now, when VTAC is greater than 200, then it becomes really, I mean, here you can tell, because here's the QRS and here's the T, but sometimes it just sort of smooths out and kind of looks like this. I never use the term ventricular flutter. You can if you want, but I don't require you to. The only reason I put it in the lecture is if somebody talks about a patient being in ventricular flutter and you think, wow, I never heard of that. So I don't want you to be confused. So V flutter is simply VTAC that's gotten fast enough. It's no different, it's just rapid VTAC, okay? So I'll just leave that to you to read. And again, we've already said this. So what happens when the myocardium in the ventricles gets very ischemic or there's electrolyte imbalances is there tends to be very discordant, if you will, areas of conduction. You'll have an area of slow conduction beside an area of faster conduction, just because of the ischemia or the electrolyte imbalance or whatever is happening in it. And when you have these patches of differing conduction, that's when you can set up the conditions to form a re-entry circuit. Okay, the way we described it was if there's an area that doesn't conduct at all, but you can get the same thing when you get an area that just conducts very slowly, okay? So you don't actually need to remember that specifically, but I do want you to know that ischemia, electrolyte imbalances, some drugs will set up conditions that allow these micro re-entry circuits to form, and that can lead to VTAC. Okay, so ventricular escape or idioventricular rhythm, less than 40, accelerated idioventricular 40 to 100, VTAC greater than 100. So that's the way to remember. So take a few minutes, everybody, and look at on page 25 and 26, 5, 6, and 7, and say whether they are ventricular escape, accelerated idioventricular, or VTAC. People pretty much done?
It's a minute, please.
Okay. Okay, so Cody, strip 5. What did you call that?
So, this would be VTAC.
What's the rate on it?
I got 111-ish.
Really?
That one looks different than mine.
Which one are we on?
Oh, is
We're on
this,
page 25.
is it, is it different?
Mine looks a little faster.
Okay. Oh, you're right. Okay, so 10, 20, oh, I bet I changed it because it's right on the border, 10, 20, 30, 40, 70, 80. Okay, change that one. Okay, so, do this one.
That one? Alright. 1, 2, 3, 4, 5, 6, 7. It's about 80, so it's between 40 and 100, so I'm gonna say accelerated.
Yeah, so this one's accelerated. I'm guessing what happened is the one in here, is it right on about 100? Yeah, so it was borderline, so it was a bad example of what to
So this
use.
is also known as ventricular escape.
It's accelerated ventricular escape.
Accelerated.
Okay, so what's the bottom cutoff for accelerated versus ventricular escape? When does it become accelerated?
Between 40 and 100.
Yeah, 40 and 100. So the one here is accelerated idioventricular rhythm, AIVR. The one in the handout is right on the border, so it's kind of a problematic one. Okay, but this one I think is the same. So Chris, strip 6, please.
This is looking like VTAC to me.
It's looking like VTAC to me as well. Okay. And then Ann, number 7.
Well, that is maybe borderline as well. If it's 40, it's 40.
This one is, if you look at the R to R's, 10, 20, 30 is, I don't think it's even
Then
quite
that's
40.
the
Yeah.
escape.
Yeah, so just escape. Okay, so this is one of those bookmarks that you don't actually, if you look at the slide and say, I have no idea what's on that slide, don't worry about it. I'm just kind of a bookmark for things to come next term. So there's something called SVT with aberrant conduction, for example, SVT with a bundle branch block. For now, no worries about that. We're just going to pretend that doesn't exist. So if you're sitting there saying, well, I don't even know what it means, that's fine. For us right now, it doesn't exist. For now, all wide complex regular tachycardias with no obvious P waves above 100 are going to be VTAC. So just call it VTAC and don't worry about any of the other possibilities. We'll get to them in time. Not this term, though. Okay, so now we're going to talk. Have you all heard about torsades at any point? And have you done it in lab or you just heard about it? Yeah.
I heard the name, I have no idea what it is.
Okay, so the actual, it's a French term which means twisting of the points. Typically, people simply call it torsades, okay? It's a form of what we call polymorphic VTAC, and what that means is that the VTAC has multiple morphologies, and you'll see it in a minute. It occurs in the setting of delayed ventricular repolarization, which is another way to say prolonged QT interval. Who remembers what the QT interval is? Where does it begin? Where does it end?
And
Cody?
the PRI and the T. ST?
Yeah, so the beginning of the QRS, you're right. The beginning of the QRS to the end of the T. So the beginning of ventricular depolarization to the end of ventricular repolarization is the QT interval. You don't want that to be too long. It's a bad situation if you have what's called a prolonged QT interval because it prolongs that vulnerable period at the end of the T wave. And what you become, one of the dysrhythmias that can occur if you have prolonged QT interval is torsades, okay? So this is what it looks like. It's a very specific form of VTAC, and you can see how the amplitude is, you know, it's very high, and then it gets low, and it's high, and it's low, and it's high, and so that's the twisting part. Like, you know, you'll hear people say, oh, it's like taking a piece of crepe paper, like for a party, and you twist it, and it you know, it has these like that. It can be difficult to see in a 6-second strip. So for that reason, the only 6-second strips with torsades I use are the obvious ones, like this. Sometimes you just can't see the pattern of it very well in 6 seconds. Okay, so reminder, here's the QT interval from the start of the QRS to the end of the T wave. And we're going to go through this, we did this earlier in the term. So a prolonged QT interval, the length of a normal QT interval depends on the heart rate, okay? In general, for rates less than 100, the QT interval should not be greater than half the R to R interval. Okay, we did this earlier in the term before you really knew an R to R interval. Right now this should be pretty easy. At faster rates, the QT interval becomes more complicated to calculate, and we're not going to worry about it. However, I do want you to know at rates less than 100, if you take the R to R interval, and there's half, and there's the QT interval from the beginning of the QRS to the end of it's an inverted T wave here. So is that normal or prolonged? Yeah, it's normal. Okay. Now, prolonged QT interval is very undesirable because it can lead to an extra long relative refractory period. And that leaves the heart vulnerable to dangerous dysrhythmias. So what causes a QT prolongation? There are some drugs that do so. Electrolyte imbalances can do so. And then there's some people that are just born with it. You'll hear people who have congenital long QT syndromes. They're just born with a longer QT interval. It's not a good thing. So the characteristic pattern of torsades is caused by the repetitive spinning of the main vector. So what's happening is that the ventricular depolarization, it's spinning and it's shooting off these impulses in kind of a sort of a circular way around the ventricles. So what you can see here we have a normal sinus rhythm, and you can see how the QT interval, so here's the end of the QT interval, it's quite long. And we have a, here's the first, here's a PVC that occurs, and that leads right into a little run of torsades, and then it goes back into a sinus attack. Now, typically, torsades is short-lived and terminating. So if you come in and the person is sitting there talking and you see little runs of torsades, again, the treatment is magnesium, and that's how you would treat it. Okay. Okay, this keeps us in business, VFib. So completely chaotic electrical activity in the ventricles, it's always pulseless. It's always pulseless. It's impossible for it to be with a pulse. Okay? If you walk in and you look at the monitor and it's V-fib, it looks like V-fib and the patient is sitting there talking to you, it's not V-fib. It's some kind of really weird interference in the monitor. Okay? There is no rhythm, there are no QRSs, there's no rate, there's no P waves, there's no PRI. I mean, it's kind of an easy ECG. Okay, so VFib.
How does that differ from PEA? Is that what it's called? Pulse?
Oh, good question. Does anybody know the answer to that one? Yeah.
How about a PEA looks like a totally normal organized rhythm, there's just no pulse associated with it.
Yeah. Now, but that being said, logically you're correct. Because this is electrical activity, okay? As long as you're seeing something happening, there is electrical activity in the heart, and there's no pulse. So logically you're correct, this is pulseless electrical activity. However, we reserve the term pulseless electrical activity for an organized rhythm, for something with a QRS and no pulse. So it's just by definition. Yeah.
How long can someone exist in PEA? Or how long can that electrical activity persist?
In PEA, it sort of depends, I mean, of course I can't give you an answer.
Yeah.
But it does kind of depend on why it's happening. Like, there is a form of, I'll call it pseudo PEA. You simply, the pulse is there, it's just so faint you can't feel it. But really it's no different than any other cardiac arrest, right? I mean, the importance is not the electrical activity, it's the fact that there's no mechanical activity. And so when it comes down to it, you can exist in cardiac arrest for the, a handful of minutes, and then you die. So, yeah.
We worked a code that the guy had probably been in PEA, cardiac arrest, for several hours.
How old was the person?
Late 20s, early 30s.
Yeah, so this is a particularly gruesome story, but it's true. I was called to a scene, and it was a neonate, just been born, and they didn't tell us at the time. It was a very young mother, and the baby had, in fact, been born dead. But they didn't tell us that, so all we knew was we had a dead baby. So, of course, we pulled out all the stops, and we intubated them, and gave them epi. And we got a rhythm in the heart. The thing was I don't know why the baby, I didn't know anything about it. I'm sure there's no, because the mother was so young, I think there was very little neonatal care. It was born at home. But essentially that baby never took a breath, never lived. And probably by the time we had gotten there, it probably was like 10 or 15 minutes after they had been born, and we were able to get so. Yeah, so it really depends. If there's nothing wrong with the heart, you can get a heart to beat by giving them, by intubating the person, giving them some CPR, and really it was the epi that did it. So, yeah. Okay, so, again, VFib always accompanies cardiac arrest by definition. And then asystole. Okay. Asystole, no electrical activity or very little electrical activity may be the first event in cardiac arrest, final ECG, and all deaths. So there's nothing there, okay? Now, this is a very extreme example. Typically, there's maybe a little bit of, wavering on the baseline, but that's asystole, okay? So, question for you all. I don't want the class to go past 11:15, between 11 and 11:15. Do you need a little break just to get that far, or do you just want to barrel on through? Everybody's looking a little. Barrel on through? Is that what that is?
Yeah, let's go, man, let's
Okay.
do this.
Okay.
But if I'm the only one that
Any-
feels that way, I'll shut up and we can take a 5-minute break.
Okay.
Let's keep going.
Okay. Okay, we're going to talk about IVCDs. Okay. So we know that all ventricular rhythms have wide QRS complexes, and this hopefully is very old news for this class. Does it follow that all rhythms with wide complexes are ventricular rhythms? Koa, what do you think? No, exactly. We've known this for weeks, okay? So, it is possible for a supraventricular rhythm to have a QRS if there's an IVCD. Again, very old news. Who remembers what are the causes of IVCDs? So bundle branch blocks was one letter in the corner over there. What else? What else? Drugs? What else? There we go. Thank you. Okay. Okay, causes of IVCDs. Bundle branch blocks is by far the most common cause. Okay. So, what causes a bundle branch block? So, normally the impulse travels down the AV node, travels down the right and left bundle branches at the same time, and the left and in a healthy heart, the left and right ventricles depolarize quickly and simultaneously, resulting in a narrow QRS. When we see this R wave, that's the left ventricle and the right ventricle depolarizing at the same time. Okay, but then what can happen, so here's the left bundle branch, here's the right bundle branch. If a block occurs in one bundle branch, the ventricles depolarize sequentially, one after another. The one that is blocked depolarizes more slowly. Okay? The impulse travels down the unblocked branch and stimulates the ventricle on that side, but the block side has lost the advantage of the speedy conduction system and relies on that slow cell-to-cell depolarization. Okay. So either left or right. Okay. Because of the wide QRS, the presence of an IVCD, knowing that there's an IVCD, can be determined in lead 2. We've talked about this all term. If you have a supraventricular rhythm, sinus, atrial, or junctional, and the QRS is wide, we know there's an IVCD. However, a 12 lead is needed to identify, this should just be confirmed, that the IVCD is a bundle branch block and also determine whether it's right or left. So one of the things we're going to do in winter term when we start talking about bundle branch blocks is look at the 12 lead, and pretty quickly you'll learn to say, oh, it's a left bundle branch block, it's a right bundle branch block, but we can't do that with just lead 2. With lead 2, everything remains the same except that the QRS is greater than or equal to 0.12. So let's look at whatever page we're on. I think it's 25 or 26. So 8A and B, I want you to take just a couple minutes and say what the rhythm is in 8A and B, okay? And if you see an IVCD or not. So what the underlying rhythm is and if there's a IVCD present. Okay, Andrew, what are these strips here?
Looks like normal sinus rhythm with an IVCD.
Yep.
The bottom one's, keep that.
I'm sorry, what was that?
Well, the bottom one looks more like those like rabbit ears.
Yeah, it does. So, just kind of a little bit of common sense. As far as I'm concerned, if the next quiz, because one of the things you'll be asked to identify is, do you see an IVCD? If you say normal sinus rhythm with an IVCD, you're done. That's all you have to say. That being said, when you have rabbit ears, it's more likely to be a bundle branch block. Okay, so if you want to say bundle branch block, that's fine. But if you want to just make it easy on yourself, anytime you have a supraventricular rhythm with a wide QRS, just say whatever the underlying rhythm is, in this case normal sinus rhythm with IVCD. Yeah, Cody.
I'm not understanding, how did he identify that there's IVCD?
Andrew? Or Koa, you were the one that did it, right? Which,
No, I
Andrew,
did.
sorry.
Normal, the underlying rhythm is normal except for the YQRS.
Yeah, it's a wide QRS. So first of all, do you see why it's a normal sinus rhythm?
Yeah, because it's regular.
And what else?
P waves are up.
P waves. Okay, remember the P waves. We're going to, in a little bit, we're going to start doing ventricular rhythms, and they're also regular, but they don't have P waves. Okay? So it's a normal sinus rhythm because it's got a P wave. It's regular. There's a P for every QRS, a QRS for every P. The P waves all look alike. Okay, the same criteria stands. But then when we get to the last step, so this is a particularly wide, this is a really nice wide QRS. There's a Q wave and the J point is here. So it's at least 4 small boxes, which means it's too wide. And what's the reason that a sinus rhythm will have a wide QRS? We don't expect it. Sinus rhythms are supposed to have narrow QRSs, but Cody, what's the reason that a sinus rhythm has a wide
It's because
QRS?
there's a bundle branch block, or sorry, IVCD.
Yes.
So it slows it.
Yeah, slows depolarization, correct. And then same thing on the top one, it goes from here to this is the J point. Does that make sense?
Yeah.
Yeah, okay. So if you're asked, as you will be on the next quiz, is there an IVCD? That means you have to just measure the QRSs, okay?
Is it gonna be all strips?
Nope.
Or-
Nope,
That's
it's,
what it's gonna
I can't remember what the percentage is. I think it's about 1/3, 2/3 question strips, I think. I'll double check.
do. Is it cumulative? Like, is it gonna be a lot of?
No, quiz 1 and quiz 2 are not cumulative, but the final will be. Okay, yeah. Check. We'll go over it next week, but the study guide is up, so you can check. Okay, so the presence of rabbit ears are prime means the IVCD is most likely bundle branch block, but you can forget about that for now. You really can, and just say normal sinus rhythm with IVCD. Okay, that's really the easiest way to proceed. So again, if we look back at 8A and 8B, this IVCD may be a bundle branch block. This one is probably a bundle branch block. But again, all I'm requiring is bundle branch block. So in this case, this is number 9. I'll just give it to you. Sinus TAC with IVCD, again, most likely bundle branch block. Okay, what about number 10? So look at number 10 and figure that one out.
Just gotta make sure.
Okay, so who knows what this is? It's not VFib because it's got organized QRSs.
It's like AFib.
AFib, and then what's the other significant part about it, given what we're talking about right now? It is AFib. So,
IBCD.
yeah, it's got a wide QRS. So it's AFib with an IVCD. So most of the time you see IVCDs, they're going to be on a normal sinus rhythm, but they can accompany any supraventricular rhythm. So if the person has a bundle branch block, for example, and they go into AFib, they're going to have a wide QRS. So don't ignore the fact that now when you do AFib, you're going to have to check narrow or wide, and if it's wide, it's an IVCD.
So I was measuring the QR, or wait a second. I guess am I measuring the QRS wrong? Because it looks like it's like right at the border of 3 small boxes. You know?
Well, remember that it's has to be less than 3 small boxes, first of all.
Right.
Okay.
Right. Which
So I would say the J point's about here,
oh, okay.
and here. So I think it's
Yeah, no, it's.
yeah, 3.5, 4 boxes.
I was measuring it wrong.
Yeah. Okay. Okay. Now, both ventricular rhythms and supraventricular rhythms with the IVCDs have wide QRSs. And people get that mixed up sometimes, and they'll look at a ventricular rhythm and they'll say, oh, it's accelerated ventricular rhythm with an IVCD. That doesn't make any sense, okay? A VTAC is always wide. And if you, let's say you have a patient in VTAC, and they have a pulse, and you cardiovert them, and they go back to a normal sinus rhythm, there's every chance that it could be a narrow QRS when they're back in a normal sinus rhythm. It's the fact that they're in a ventricular rhythm makes the QRS wide. Okay, so for that reason, it makes no sense at all to talk about a ventricular rhythm with a bundle branch block, unless you happen to know that, or a ventricular rhythm with an IVCD, because the ventricular rhythms have wide QRSs because they're ventricular rhythms. Okay, so for example, this is a ventricular rhythm, and the answer, if I say to you, what is this? Well, the answer is ventricular escape. It is not ventricular escape with an IVCD. The reason that this QRS is wide is because it's a ventricular escape rhythm. It only makes sense to use the terminology of IVCD when you have a supraventricular rhythm. Does that make sense? Well, next week we'll practice a lot, and I suspect that mistake may come up, and we'll go through it again. Okay, there's a problem with Huff. The only type, so this week you'll be practicing in the ventricular, in the section that covers bundle branch blocks. Huff does not use the term IVCD. I don't know why not. All they talk about are bundle branch blocks. So every time there's a wide QRS with a supraventricular rhythm, they always say it's a bundle branch block. Okay? I don't want you to do that. I want you to use the term IVCD. Later on, when we get to 12 leads, we're going to be more, then we can be more precise. But for now, we're going to use the umbrella term. Okay? Does that make sense? Okay. The next part's really quick, so we'll go through this, and then we'll call it a break, call it a day. So, pacemaker rhythms. We're not talking about the transcutaneous pacemakers that we do. We're talking about implanted pacemakers that people have in their heart. Now, just to be really clear, I don't know a lot about pacemakers other than as how it relates to ECGs. Okay? But you will have plenty of patients that have pacemakers implanted. Usually they're implanted because the person's heart rate is just too slow. And sometimes it's just because the heart conduction is unreliable or some combination. Typically, pacemakers have the machine itself. You'll see it. Has anybody seen some people with implanted pacemakers? You can see it under the skin, and then it goes into the subclavian vein and down into the heart, and the tip of it will be in the ventricles. Alternatively, there's something called a dual chamber pacemaker, which paces the atria first, followed by the ventricles, so they get atrial care. Okay. Here's a real picture. Really commonly, you're going to have people that have demand pacemakers. So what that means is mostly when people, their heart rate gets too slow, a lot of times, sometimes it's fine, and then it gets too slow, and then it's fine, and then it gets too slow, and then it's fine. So it makes no sense to just continuously pace them when most of the time, or much of the time, their heart can do it just fine. So a demand pacemaker will be set to a certain rate. Let's say it's 60. If their heart rate falls below 60, then the pacemaker starts pacing. Yeah.
So I've had patients that call us and say, like, my pacemaker's going off, I need to go to the hospital.
Mm-hmm.
And Fire was like, well, that's bullshit, it's just doing what it's supposed to do. So it's not inherently an emergency if you put a pacemaker on.
Well, it depends on if it's truly a pacemaker. It may be that they have an implanted defibrillator. And that's what I don't know for sure.
Mm-hmm.
It may be that it was a pacemaker, but the call that sounds most familiar based on what I would be called on was that people have implanted defibrillators if they have a tendency to go into VFib or VTAC. And when they go into VFib or VTAC, it essentially defibrillates them, and it's implanted. And that can be really annoying even if they actually are going into VTAC, the fact that they just keep getting defibrillated. So, for example, I remember walking in once and the guy was holding a magnet over because that stops him. And he was actually in VTAC, but he just couldn't stand the fibrillation.
So it depends on what device
it depends on what it is. And the other thing is it was a pacemaker that was malfunctioning, going too fast. Yeah, so I don't know, but I would not, my own tendency would be not to call bullshit on the patient until I knew a little more about it, because they maybe know more about their pacemaker.
Yeah, I was like, I know nothing, so.
Don't
Yeah.
they beep? I think they beep if the battery's dying.
Yeah, that could be the other, right,
Yeah.
that could be the other
Heard
thing.
that before.
Yeah. Okay, so generally speaking, we're not going to get into big depth with pacemaker rhythms. I'm only going to require you to know 3 different things we could get. I think Huff gets very elaborate with reading pacemaker strips, and that's not useful for us. I do want you to know these 3 terms. The 2 most important are ventricular capture and intrinsic beat, and you can just say capture beat, to be honest. Intrinsic beat and then fusion beats. So what are these? So on this strip, you can see, here's the underlying rhythm, right? It just looks like by the way, what is this rhythm? Who knows? It's AFib. So the person is in AFib, and then presumably it starts to slow down, and their pacemaker kicks in, and it's hard, especially hard to see on the, this always gets a little smudged when I project it, but you can see the pacer spikes, okay? So capture beats typically will look a bit like PVCs. They're kind of wide beats, usually with no P wave unless it's a dual chamber pacemaker. And then it goes back to AFib, and then it goes back to the capture beats. So if you had this on a test, what I want you to say is that there's intrinsic beats, and if you're able to identify the underlying rhythm, no problem here, you can say, run of AFib with 2 capture beats, followed by a little bit more AFib and another capture beat, okay? Or you can say pace beats, that's what I have here, capture or pace. Okay, this are just the spikes, okay? So this person's died, but their pacemaker's still going. I know. What can I say? You're going to be a paramedic. So this one is, you can see the capture beats or pace beats. You can call them either capture or pace. That's okay. And be careful, because at first glance it looks like a little bit of accelerated idioventricular. Look for the pacer spikes, okay? And then we have an intrinsic beat. It's probably a junctional beat, but it's a little hard to tell because there's just one. And then there's this odd thing called a fusion beat. And what happens, actually this is really interesting because it looks as though there's a P wave here. So the heart's starting to go into a sinus rhythm, but just then there's a pacer spike. And so the underlying rhythm combines with the pacer, with the pace beats, and forms something called a fusion beat. Okay. Not, in all honesty, there's nothing important about fusion beats other than I don't want you to be confused about what it is. Okay. So, and then here's just a straight paced rhythm. Again, look for the pacer spikes. Okay, this is the 12 lead, but this is where there's a dual chamber. You can see there's a little pacer spike, then there's a P wave, and then there's a pacer spike, and then there's a QRS. So this is where the atria and the ventricles are being paced. Here's another one like that. You can see. So another. Just to give you, on the 12 lead, you can just see the pacer spikes. And here you can see here's an intrinsic beat, and then it goes back to the paced beats. Okay, so that's the end. So for this week, what we're going to do next week is going to be all practice. And I may start class a little late next week. Look for an announcement, because 3 hours of practice is quite a lot. So let me check to see what we want. So I might start at 10.